in the chat during the presentation. You can start doing that as it goes along. At the end, right before Q&A, I am going to unshare, or I'm going to share my screen, and we have a QR code. Please take a picture of that QR code because that is how you will get your CE. Please fill the QR code out within 7 days, and then we will upload everything and email you back your certificate for continuing ed. So before, let's get ready. I'm going to introduce Ms. Sheila Roth. Sheila Roth is the Director of Clinical Operations for an AI company. She's going to be giving a great presentation on AI. It is somewhat generic. It's not focused around her company, but it's very, very interesting, and I'm looking forward to it. Thank you, Sheila, for joining us this evening.
Well, thank you so much for having me, and grateful to be here. Fellow hygienist as well, so I have a lot of unique perspectives here that I'm sure you guys can all relate to on this call. But really, the take-home message here when we're finished is, wow, what is AI? Do I really need it? And do I want to talk about getting it into my practice? And I think we hear a lot about AI in dentistry. And when we walk through efficiency, diagnosis, and case acceptance, we're going to share stories about how we can all use AI to make our life and our day even better. So let's dive in. Now, it's really important to start with a simple definition of what AI really is. And when you think about it in its simplest form, it's really pattern recognition. And when we think about AI in general, it's just humans being able to feed a lot of data into a different format and outcomes an algorithm. The definition of AI is really about teaching the computers to do simple things and have decision-making capabilities without the humans involved. So we'll get into that a little bit more as we look at AI in dentistry, but we are already all using AI. In fact, about 6 years ago when I started talking about AI, it was interesting when I would ask, whether I was presenting live or on a webinar, has anybody used AI? And there was not really a hand ever raised. Funny enough, we've all been using AI. It kind of crept into our world without us even knowing it, right? So we have basic things like GPS or, my favorite, which is Netflix, right? Go, Sheila, you're watching this. How about this? And I love that. And there's a lot of ways that we're going to go through thinking about how we can use AI in our day to buy back time for us that ultimately we can spend more time with our patient. Now, when we talk to a lot of different clinicians that are using AI or a lot of clinicians that don't want to use AI, there's really right now, we're moving into mass adoption, but there's still two camps. And it's important to recognize both. One that's saying, I love AI, it's so great, it's innovative. And then there's another camp this is kind of scary, and I don't really need it in dentistry, but I really think it's interesting, but is it going to take my job? And the good news here is it's not going to take our jobs. But when we're looking at ways to really focus on that patient interaction, we're going to go through things like chart audits and x-ray reviews and things that you don't want to have to do as a human, so that you can spend that time with the patient. A lot of times people think that AI just popped up overnight over the last few years. In fact, when I started getting into AI, I didn't even know it existed back in the day. And really, the birth of AI was back in the 50s. And when we look at why AI really became such a boom in our lifetime right now, it's because we finally had the ability to take a lot of data and scale that data. So we have more computing power, which allows us to crunch numbers faster. And our outcomes are actually more accurate, meaning when we're making models, it's much more inexpensive, easier to do with computing power. And also we're able to scale that over multiple different algorithms. Again, I'll get into what I mean by that, but it's only really been the last 10 to 12 years now that we've been able to move into the AI space in a more profound way. We also now see most of us using agentic AI, and we'll get into that in just a moment. I think it's also important to understand how AI is trained. Now, we're going to talk today mainly about radiographic AI. But there's a lot of different ways to think about AI in the dental space. Phones, right? People are having AI answer the phones. We'll get into that. Chart audits, voice recognition. But really, when we think about how does the AI learn what a piece of calculus is, or a bone level measurement, or an incipient lesion versus a progressed lesion, or a periapical radiolucency? And it was really fun working with the teams that were conducting the FDA trials to learn that, again, it's really simple. Now, it's a very laborious process, a lot of regulations, but in general, once we had digital images that gave us the data, large data that we needed, the dentists, which have a specific, we had to have, what was it? I think it was 8+ years out of school and US trained in order for it to be an FDA cleared clinician that could work on annotating pathologies. And annotating is a fancy word for circling, right? So they would take a bunch of x-rays and they would circle a cavity. They would circle a periapical radiolucency, boxes around calculus, notable margins, and then drawing lots of lines from CEJ to bone crest, and also kind of the top of the apex all the way down to that coronal portion of the tooth. In doing so, you had to prove that the AI and the human were better together to get that FDA clearance. But from all of that training, you now will see in real time, you take a radiograph and you will see those pathologies appear. Important to know that the tool for AI radiologic side is not a diagnostic tool, right? It's an aided tool. So it's not there to diagnose for the clinician. It's not going to say, here you go, need to do a DO on number 2. That's actually left for the doctor to make that decision. So I think that's really important that as we move through AI today, we're not removing autonomy, and we are not trying to move into a space where the AI is going to direct the diagnosis of that patient. Interestingly enough, when we looked at the clinicians that reviewed the pathologies on thousands of images, we found that the dentists were great, not perfect. When we looked at the AI and we said, how did the AI do? Did it find that incipient lesion versus a progressed lesion? Did it find, there's a lot of confusion between cervical burnout and a progressed area of decay, as well as it liked to circle the mental foramen a lot as a periapical radiolucency, right? Because AI is in its infancy stage. And you see, it still has to learn. When I started with the FDA team, I was thinking, guys, how come this isn't so much easier and faster? Can't we just give you more x-rays and make the accuracy even better overnight? And I had to learn that it takes so much data to have accuracy improve. And the models that we're using for radiographs are always continuously improving. They don't require any clinicians to make adjustments. They're always being worked on 24/7 to ensure accuracy. But when we looked at the AI, it did great, not perfect. Interestingly enough, in the studies, we found that the AI plus the clinician was really the game changer that provided the most accurate output. So when we look back at the history of modern dentistry, we see these technological advances that have truly pushed the industry forward, all the way back from braces and amalgams and dentures, moving forward into, fluoride, the high-speed drill, implants, digital dentistry, intraoral scanners. I will date myself, but if I could see you all, I'd have you raise your hand and say, how many of you were dipping radiographs back in the day, right? And then we had that big fear of moving into digital imagery. And what was that going to be like? And how are we going to adopt that? Or moving into the mandated chartless days, right? Chartless. Well, really, it is chartless, where you had to go into digital charting. And I thought, wow, how are we going to put all these charts into a computer? And we look back and we think, okay, we overcame all of that. And it's the same when we think about AI, right? How are we going to actually move into using AI? And how are we going to use that in dentistry? We've been here before where we're looking at a new technological advance that's really going to push us. Now, interestingly enough, our space takes about 1.4 billion radiographs per year. That's dentistry, more so than any other profession. So we've really kind of leapfrogged medicine when it comes to how we're using AI and how frequently we're using AI. We've moved away from, dark rooms, and digital x-rays and paperless charts, and digital impressions are now here. And in-office milling was a big deal, right? Remember back in the day where somebody would say, can you imagine making a crown the same day? And all of these things are moving through the space with digital impressions and in-office milling using AI. What about the lead apron, right? Again, thinking about 10 years ago, 5 years ago, would you ever think you're going to take an x-ray without a lead apron? And here we are. You don't need a lead apron anymore. So a lot of changes that continuously happen in dentistry. And there's a whole new language, right? We're talking now about digital x-rays, CBCT, CAD-CAM, intraoral scanners, DICOM, milling units, zirconia, teledentistry, digital workflows, guided surgery, and now we've adopted AI detections. So we are an incredible group of professionals that are always willing to learn and wanting to adopt new things, but also that fear of change, right, is a concern. We're all humans. So we talked a lot about how dental AI is trained, basic algorithms. It's important to know that the AI is really looking at different shades of gray. And if we, again, could take everybody off mute, we would ask you what the human eye, as far as shades of gray, can see versus what the AI can see. And the human eye can see hundreds of shades of gray, whereas the AI can see thousands of shades of gray. And the nice thing here is we all are in this profession to treat the patient as greatly as we can, whether that's your, treating every patient like a family member is the main goal. And we want to know that when we see that incipient lesion, right, there's no manual. Do we watch it? Do we treat it? And also sometimes there's 20 of those in one quadrant. My best friend's daughter, I'm going to show you some x-rays here, where she came back from college and had, I think, 13 cavities on each side of her mouth. And so these additional data points, these shades of grays, these little incipient lesions that will show you that on the radiograph itself, it's still in that enamel. Now we need to be mindful, right, that we are taking an image of a three-dimensional tooth and using two-dimensional imagery. So when we talk about incipient versus progressed, we're really talking about how this looks on a radiograph. So today, we want to go through three main cases. We can diagnose faster because we're going to move through images quicker. I don't know about you guys, but I still love when spell check pops open that little red line as I'm typing. Now I'm usually typing in AI, so there's not as many red lines until I get it through, but it's great to have that reminder like, hey, go check this word. And that's what I want you to think about when you're thinking about AI in digital radiographs, because it's very simple to have something pop out and you see this big lesion on number 3 and you're like, wow, that's a huge cavity. But by the way, there's decay on the distal of 6 and it's moving past the DEJ. And so it's nice to have that second set of eyes, right? To be able to run 24/7, right? AI doesn't get tired. It doesn't need to take a break. It doesn't diagnose differently on Monday at 8 a.m. versus Friday at 4 p.m. It doesn't have diagnosis fatigue. When we move past radiograph review for clinicians, whether you're a doctor or a hygienist, you really move into the space that we spend a lot of time on, especially hygienists, which is communicating better. And we'll get into that in just a moment. The best silver lining I have seen with AI in chairside case presentation, well, 2 things. Number 1, I got to stop talking so much to my patients. They were thankful for that, I'm sure you can imagine. But more importantly, I was showing an area, whether it's scaling and root planing, recurrent decay, interproximal lesions. Those are kind of the top 3 that usually stump patients the most, right? Excuse me. They can look at an intraoral photo or they can feel pain or see a broken tooth, but it's the unseen that we need to help them see. And what I found was shades of gray was really unfamiliar to them. I go through my whole, what I thought was a great case presentation, and they're like, is that the right side or the left side? And I thought, oh my gosh, wow. Here I am done, ready for them to accept the dentistry. And they were not even knowing which side I was talking about. And that's very common until we've moved into the AI space where it will segment out different tooth structures and color the teeth white where the enamel is, right? But the silver lining was I could stop talking. And that gave them time to actually be more informed earlier on because they can see anatomy, they understand it. They don't need to know dentin and pulp, but they can see this pink thing moving into the next part of the tooth. And they had time to make a more informed decision and to ask questions so that I could help them understand why doctors recommending this treatment or why we're recommending scaling and root planing, right? And I think sometimes we're rushing so fast. So to buy back 2 or 3 minutes is really a godsend. So, and closing more cases, not to be confused with diagnosing more cases, right? We'll get into some statistics in just a moment that talk about case acceptance in the US. But what if, just for a minute, what if we lived in a world where the patients actually said yes to the dentistry that we recommended, right? Whether it's scaling and root planing, whether it's, one filling, whether it's a full all-on-4. If patients really accepted the dentistry that we recommended when we recommended it, wouldn't they be better off? Wouldn't it be less invasive and less expensive? Wouldn't that provide better outcomes? And ultimately keeping that happy patient that's retained in your practice for a lifetime, and they refer their family and friends. So that's kind of the practice that I've been working on the last 25 years. We have about 13,000 active patients now. There's 22 hygienists, and we see about 2,000 hygiene patients a month. We run through these cases very efficiently. What's really important is that the patient has a great experience, has the proper education, and accepts the dentistry when they feel comfortable, which with more education is usually earlier, right? So we think about if you take 5 minutes on any social media platform, you will see how unfortunately negative our profession is continuously mocked and looked at. And you guys have all probably had it where, how are you today? Oh, I just can't wait to get this over with. I hate the dentist, right? And a lot of times as hygienists, we don't hear that as much. In fact, I was in a practice this morning doing some shadowing, and it was interesting because the patient said, as I walked by, she was telling the hygienist, she's like, I would change my medical doctor any day of the week, but I would never change my hygienist, right? And I thought that was so funny. But it really is interesting when we think about we're up there in trust level with mechanics, right? We're not going to get into the mental health that we all are dealing with on a daily basis, and the concerns we have with just showing up every day in this day and age in dentistry. But we still are known as, a profession where we provide absolutely everything we can. I can't even talk. Everything we can every hour, and yet we still don't have the trust that we really deserve. Interestingly enough, the statistics will show you it's not that we're in a place where AI or dentistry in general is being overdiagnosed. Now we know we have those outliers who, in theory, are the ones giving us that bad name. But there's a huge epidemic in an underdiagnosis, right? Lots of missed fillings, lots of areas that have continuously progressed. Again, when we're treating our patients really well, the production always comes, right? And when they're understanding what we recommend, this is really the best way to grow a practice, whether it's your hygiene practice or your basic office in general, is better outcomes, more trust. They stay in the practice, they refer their family and friends, and ultimately, that's where the practice profits. It is important to be mindful that you want to choose an AI company that has FDA clearances. The good news for you is they're all cleared, right? There's a few major players in the space, and it is important to be caught up to speed on how is AI affecting my day and how is this regulated. It's FDA cleared. There's also global regulations when you're working in different countries. But the good news here is there's a lot of compliance around FDA and what it is doing in dentistry. I really like this statistic too. Over 4,000 hours to earn the right to read a radiograph, right? That's technically the amount of hours that are required in a basic dental school curriculum. And it is really fascinating when you think about what dentists do on a daily basis and what hygienists do on a daily basis, right? But 4,000 hours to be able to say, I can read this x-ray and diagnose it. Interestingly enough, I think we all agree that the diagnosis will always begin with the radiograph, right? It's important to have really good radiographs so that the AI can perform as well as it's able to. When we look at this radiograph, we're looking at different black and white shades of gray, right? In here, you're able to see, you guys already see areas of concern. I'm guessing you're seeing possible cavities around 12 and 13. Maybe some of you are seeing the calculus, you're worried about the bone levels, and we can move through different ways of looking at AI. In fact, this will show you those 2 lesions on 12 and 13 as progressed areas of decay. I love the slide because, like I started in the beginning here, I had to explain a lot of things with the patients about recurrent decay. What do you mean I got a cavity around a filling? What do you mean you can't just take the filling out and replace a new filling, right? Or why can't you just patch it up, right? And also the next discussion is now instead of before it gets into the nerve of the tooth, right? Now, when you're looking at this x-ray, so take a quick second. Did you see, you can also hover over and see the breakdown of that progression. Did you see the distal of number 20? Right? So that's another one. You're moving through it. Now, I know all of us are not allowed to diagnose, but we're looking at x-rays a whole lot around here as hygienists and obviously the dentists that are on the line. But what we do see is the ability to go through and review images faster, right? It's kind of like me putting on my glasses. I don't even know where they are. Here they are. And it's like, and that's how it is when you're going through radiographs consistently. And then we also have the calculus boxes. Now, hopefully, this is actually an image before root planing and not after. Although for 20 years, I still have trouble with the distal of 15. I don't know. They need new instruments or I just needed to retire, one of the two. But I really felt thankful for AI when it came to patient education, when we're explaining areas of concern, right? These calculus boxes, believe it or not, having a box around a piece of calculus is really helpful when you're explaining asymptomatic SRPs, and also to a new patient, and also to most patients who've never heard of a deep cleaning or a scaling and root planing. They don't feel it, they don't see it, right? And I think this has been really helpful, especially when it comes to, and I'll show you in a little bit, the bone level measurements. So when you move this chair side and you're talking to a patient, again, we're living in black and white images all the time where we're saying, hey, do you see this area of concern up here on number 13? And the patient's like, oh, this is perfectly healthy. But this 1 millimeter over, this is terrible. And you got to hurry up and get it done, right? And we're still doing this. And I think the good news here is to know you can move through images much faster. And you can also use these chair side with your patient. I love that AI allows us to have the next level of case presentation. This is much easier to explain bone level measurements, or let's keep an eye on the small little area of concern on the bottom there, Ryan. And on the upper, you can see those big pink areas of cavities. We're going to need to take those little like yellow fillings out and put a new crown in here. Any questions? Now that really takes case presentation to the next level. In fact, we still see patients coming in for their recall. I hope my yellow ones didn't turn to pink, right? And that's when you know that the patient really was invested in that conversation. 65% of people are visual learners. What's interesting is we've done some studies and found that 64% of patients have no idea what you're showing them on an x-ray, right? And we still do it every day. So that's where we can use AI to help with radiographs for ourselves, and more importantly, in the chair, right? We can really move from looking at this image on the left, excellent for the clinician, and the image on the right, excellent for the patient. And that's really where We could just end the webinar here. We won't. But because that's really the game changer. And the reason I left private practice and moved into AI was because when I saw this tool, I thought, wow, this is really the greatest gift for the patient and the most impactful thing, in my opinion, that a team can add to a practice for overall practice growth or clinical calibration amongst different clinicians, right? So those of you looking at this radiograph can probably see us hygienists are like, there's a furcation. AI is not identifying furcations at this time, but it's interesting to see if we need to explain something to this patient. Of course, they probably feel maybe a possible chip on the distal. Did you see the periapical radiolucencies, right? Or the bone levels? Now, the AI is taught to identify a CEJ or where a CEJ may be if there's an existing restoration, and find the crest of the bone. And it's an anatomical measurement. A lot of times people think these are probing depths, which is kind of funny because there are no gums on the x-rays yet. I don't think there ever will be. But the reality is it's really nice as hygienists to move through images faster and think, looking at my yellow lines versus my perio charting and how am I doing today? And is there progression there? Are we stable? And I think it's just nice to turn that to the patient and say, these are the areas we're concerned with. We want you flossing here. There's no bleeding. We'll see you again in 3 months, whatever the case may be. Those bone level measurements will change colors and you can adjust them, which is nice. So usually 0 to 2 millimeters CEJ to bone crest will be green. Once it moves to 2 millimeters, which is a nice alert CEJ to bone crest, it'll be yellow. And then as you move past 4 millimeters, then that turns orange. Now, when you're looking at a periapical image, I'll show you in a moment, you will see percentages of bone loss because now you can do a ratio between that CEJ to bone crest as well as that apex to the coronal portion of the tooth. It's also nice on panorexes, right, to be able to educate the patient. Panorexes, believe it or not, are pretty standard in the UK and the EU. So they use these a lot for diagnostics. I do like this line that AI really makes the invisible visible for your patient. And we're not talking about areas, right, that you guys know the patient is going to accept the dentistry on. It's nice if they haven't been in a long time, they understand they may need deep cleanings, or if they have a chipped tooth or a symptom. But what about all of the other teeth? What about all the watches? What about all of those areas of recurrent decay? What about things we're trying to save them from, right? One of the things that I feel terrible about is when my patient will come and be like, Sheila, you told me it was going to break off. I just didn't get in here soon enough. And now what do I do? Can we just put a crown on? And I'm looking at the tooth thinking, that's implant, my friend, right? And that's not a fun thing for any of us. We don't want to lose teeth. We want to have the ability to share areas of concern early and often. So this is an interesting story too, because we have a patient that came in, lots of areas of interproximal decay. And you can see here, different shades will identify areas that have moved into the dentin. Now we opened up tooth number 14 on this patient and was able to confirm there is dentin, there's decay there into the dentin. Bone level measurement wise, this is where you're seeing the percentages of the bone loss. On the bite wings, the AI will read CEJ to bone crest, which is really kind of an anatomical measurement, right? Whereas when you're looking at the entire tooth, you can look at the bone loss. Now, those of you that are working with insurance, it is nice to send your standard documentation, but also to be able to send this image in as well as one more way to prove that these patients needed that scaling and root planing, right? So as we see insurance companies continue to move into requiring more documentation, this is a great way to get ahead of any kind of denials. There is now FDA clearance for 3D images. At this point, I think there are 2 companies now that will allow periapical radiolucencies and some areas of decay. Most are still working with the anatomical segmentation, the the IA nerve, the floor of the sinus, and being able to use these areas to measure for implant placement and such. So I do think that moving into buying back your time is a great reason to think about AI. In the practice that I consult for still, last month alone, there were 490 missed calls, right? And that practice has been around 25 years. And unfortunately, the owner doctor passed away about 5 years ago and looked at me and said, "You're going to have to manage this practice." And I looked at him and I thought, "What are you doing? You are not leaving me." And this poor man who I worked alongside as a mentor and a partner passed away within 12 months with a thriving practice where we had 2 associates and at that time 17 hygienists and that time 11,000 patients. And we found that bringing AI into the practice to buy back our time was really a huge win. That's why I think I have a unique perspective here is everything I'm telling you today with some of the things I'm going to jump into in a moment, I have used and I have tried in a live practice. So because of those 490 missed calls, we don't want to use AI, quite frankly, to answer the phone, right? I would love to have 20 extra people that could do that. But right now, with the people that are answering the phone, it's really the last thing, which is unfortunate, that they can get to these days. We have a lack of staff. I don't know if any of you are looking to work in the front desk. Let me know. No, I'm just kidding. But it's really challenging to do all of the dentistry we need to do without the staff members that we need. So we're starting to move into technology. And I thought, well, it's probably better for a patient to know that it's an AI, which I think is important, and take the message and email the team to get a more immediate response, right? Patients, believe it or not, are also 65%, everything is 65%, are scheduling online. And they're scheduling online after hours. So if you have not looked into online scheduling, that's another huge asset that we can lean into. I think there were 74% of new patients prefer to schedule online, and they're doing it between like 2 and 5 in the morning, which is really another whole nother webinar. What are people doing up scheduling dental appointments that early? But it is interesting to think about this, these 2 camps we discussed earlier, which is, I love it, it's great technology, it does everything for me, or am I no longer going to work in the front desk? And I would encourage you to sit back and think, what could we automate so that we could have more time in our day? One of the other things is insurance verification, right? When the patient makes an appointment, now you can have a company come in, verify the insurance, tell you eligibility, tell you frequencies, and alert you of areas of concern. This is really great because now those people are still going to verify all the patients they have to call insurance companies for, but those people that have been, like in our practice, living in a different room are actually being brought back into the practice and their front lines, and they like being with the patient. So that's been a nice way to think about not replacing humans, but augmenting some of those mundane tasks so that we can put humans back in the place where they belong, which is with other humans, right? So that's the important part about auto-populating in imagery. You need to make sure you're working with a company that uploads the images fast. We're consistently making sure it's 16 seconds is really kind of a great amount of time. Faster chart notes, I'm going to get into that in just a moment. And really those focused patient conversations that are going to come out of those colorful images that you can use chairside. Most teams, when they're not diagnosing any more dentistry and they're just showing the radiographs chairside, you will see about a 30% increase in case acceptance just by showing those images in color and explaining to the patient the unscheduled dentistry and why it needs to get scheduled. So that's a nice way to move into a different space. Now, disclaimer, I work for Pearl, but I want you to know that all the AI companies now have a voice recording machine. And I want you guys to know that because it's extremely valuable for you to be able to know that you can walk into an operatory with a little microphone attached to the back of a chair, and you can start talking to the patient. It can record your notes, and it'll feed out all of the strange things, and it can create a soap note, and it can use AI to condense the note and put it back into your perio charting. I'm sorry, your documentation. Getting ahead of myself. The next thing is using it for perio charting. So we've tried out all different types of perio charting in the practice. You can imagine having 7 or 8 hygienists per hour. We have a lot of perio charting. We have a person that stands around, does instruments, and does perio charting, which is not super fun for that person. So as we've incorporated automated perio charting and the ones that work in real time and have to be fast, right? 3-2-3, 3-2-3, bleeding upper left, bleeding upper right, repeat all, undo. That's how fast it needs to work. And that's what you should expect so that you're able to use a tool the very first day. In doing that, again, we have brought that assistant to chairside, right? So thinking about embracing technology so that you can bring humans back together with humans is really the take-home message today. So you come in, your patients are verified with their insurance, your charts have been audited, and now you can record all of your voice notes as well as do your perio charting. Not to mention the AI can answer the phone. So that's really an interesting time in dentistry that we have really the great joy of being a part of. And really, we had to move to technology, right? We had to be able to have technology help us because we don't have an influx of staff. And the trajectory for staffing in dentistry is not looking good right now. This is one of my favorite parts of the morning huddle. It's important to be able to, I used to go to work and look at all of my charts. I don't know about you guys, hygienists, but I want to know everything before I get started. And I want to know, do I have to probe? Do I have to take x-rays? What's going on medically? And what's unscheduled? Because in our practice, the doctor would say, Sheila, I'm not doing your exam unless you have an intraoral photo up and the most current x-ray and no overlapping and make sure it looks good or don't call me in. And so, which I thought was a really good standard, right? To ensure that everything was ready before the doctor arrived. And that became kind of the North Star for all of us, was to make sure we had everything ready. But that created 20 minutes before work and then doing notes, right? Well, I'm slow. I still take an hour of, my time to do hygiene, even after 25 years. And I would stay for 30 minutes, hoping and praying I remembered everything. I found that charting backwards was actually helpful. So the 5 o'clock, then the 4 o'clock, then the 3 o'clock. But in the reality of life, we don't want to sit there and do chart audits, and we don't want to sit there and do notes. Well, maybe you guys do, but I do not. And nor does the 17 hygienists working consistently in the practice. They do not want to do charting. And in California, that's a giant overtime issue. So you can now find ways for these huddles that are specific to each provider. And they're going to tell you, do you need bite wings or an FMX? Are you due for probing? Is this a miscoded prophy, meaning last time it was SRP and today it's actually supposed to be a 4910 instead of a 0110? And also the unscheduled. The unscheduled is really important because that's where we need to kind of see, we used to call it what, why, and where, right? What does this patient need? Why do they need it? Is it unscheduled or new? And where is this patient at? The doctors would always say, where is this patient at, right? Not to the patient, but I'd be like, don't talk about it. And they come in, oh, so how about those fillings? And the patient would be like, I told you, I'll let you know when I want to do the fillings, right? So that's kind of how we used to operate before we started using these daily printouts. The other category here that took basic morning huddles and chart audits to the next level is a column on the right called predicted. And that's showing you areas that are, showing pathologies on the radiographs from the past before the patient arrives. It looks into the treatment plan and it says, we don't see anything for the distal of 20 we saw earlier. It hasn't been treatment planned. Typically you're watching that, right? But it'll report to you, do you want to move that to the treatment plan? Do you want to keep watching? So it allows a full chart audit, raises that clinical excellence, gives you back time, and makes sure everybody in the practice is on the same page. So why did we all need AI? And when we talked about in the beginning, how long AI has been here and how did it get into dentistry in general, believe it or not, there's a lot of studies that are showing how the diagnostic side of our profession has a lot of inconsistency. So there's a lot of studies we've all seen. Back to the Reader's Digest study, right, where we talked about one journalist, it's been a long day, who went to 50 different states and got 50 different types of diagnosis. So we've seen this. We've seen it on Dateline. We've seen it everywhere. In fact, the more it is actually displayed, the more concerned I am, because ADA did a study and showed that almost 40% of patients are still not trusting the dentist. And all of us on this call probably don't have this issue. But I love second opinions. I love when patients come in, right? Because I feel like in our practice, we just got a new patient. We're going to win them over because they went down the street and they got some weird explanation and now they're in our practice. But I want to pay attention to this middle study here too. And we took 3 different doctors with about 9,000 x-rays, and they were all asked to circle cavities. That's it, on the x-ray. Now, they only agreed with each other, is this a cavity on this x-ray, 4% of the time. But what I thought was very interesting was they came back 90 days later, and they only agreed with themselves when they redid this whole study 70% of the time. And again, that's human nature, right? But we do have inconsistency. We do miss things. When we found a retrospective study in our practice, and we have phenomenal clinicians, there were 9 teeth in 1 week that actually had recurrent decay that went undiagnosed. What we learned is that we were moving through exams too fast. And even though we have an hour per patient, we had to slow down the doctor's schedule a little bit, because it's not about the money. It's about treating the patient the right way. And everybody moved into using AI consistently. Happy to report that that number is going down. We know AI is not perfect. In fact, I asked AI to help me with this slide deck. And I asked it in this picture. I said, can you please make a picture of a very confused patient in a dental chair? Hopefully you're laughing, because I thought it was hysterical to see the patient is literally in the dental chair, right? And I had to keep the image because I thought, wow, that's actually so funny. But that really is how literal AI is, right? You tell it to show a little shade of gray and circle this, right? And again, in the beginning, it was circling pulp and cervical burnout. It's really in its infancy stage, right? But when we talk about the patients and we talk about the lack of trust, they're not resisting the dentistry all the time. They don't not believe you and just keep coming back the next day, right? We know there's cost, we know there's fear, but a majority of the patients are not understanding exactly what you're showing them. I have a patient come back for hygiene, and I'm like, okay, Bob, we got to do some of those fillings we talked about last time. Any questions, any symptoms? And Bob's like, what? I have cavities? And I'm like, oh my gosh, I got to start all over. Intraoral photo, new x-rays, AI. And I think that's what's important, is understanding we have a lot to do in the educational space. Now let's talk about case acceptance. Average case acceptance in the US is about 50 to 60%, right? I can't have you unmute, but I would love to know in your thoughts what you think the average case acceptance is in the US for new patients. We're always focused on new patients, new patients, new patients, and marketing and Google and webinars and advertising. And I now have to have my, website updated for ChatGPT directions and all this crazy stuff happening for new patients. But the reality is, with new patients, believe it or not, they typically accept half as much as a new patient. And that's mainly because, right, they need to get to know you. They need to know that you are trustworthy, and also that you care, and that it's a good practice for them. A lot of times they don't purchase until after they've had that second appointment. This statistic is very alarming. 40% of diagnosed dentistry goes untreated. That's a lot of dentistry, right? And this is diagnosed dentistry. This isn't even what the AI can pick up. And that's very concerning. And you start to wonder, why is that? when you look at a study that we've performed here, we see the AI treatment acceptance in the first 30 days for understanding the same dentistry that already existed with chairside case presentation using colors. It's really that simple. And you can see the increase here. And again, yes, this was over 10 offices. It is not, guys, about diagnosing more. It's really about meeting your patient where they are and helping them make more informed decisions, right? And I think that's really important as a takeaway message here is to be mindful that AI is not going to replace your job. It is not here to diagnose for you, and it's really not here to diagnose more. So I'm hoping that you guys can see the difference here with the good old black and white TV days, right? Where we can now see things in color. And I think that if you've learned nothing else, you hopefully understood what's available in AI and that you will be a little more mindful about adopting a few areas and trying them out in your practice. And I really just want to thank all of you for attending this evening. I'm going to stick around for some questions, and hopefully you will find one way to buy back your time so you can spend more time with your patients. So again, thank you guys so much for having me, and I will turn it back over.
Thank you so much, Shayla. That was so informative. My gosh, I learned a lot. There are questions, but before we get to that, please, everybody, let me put this into slideshow. Take a picture, not of Sheila's QR code, but this QR code in order for you to get your CEs. You'll go on, take a quick little survey, enter your license number, email, and you will get your CE uploaded into CE Broker and a certificate sent to you. So I'm going to keep this up and I can still go to, I think I can still go to questions. I wrote some of them down too. First of all, there were a few questions, more comments saying, wow, can't believe it. That's incredible. One of our participants did get bingo. They guessed it was 20% of new patient case acceptance. That was pretty cool. And that's really sad, actually. So, all right. So okay. So this is something that's really important to a few people. How do you motivate dental team members that may be resistant to utilizing new technology? Because you said you're a consultant. I know I've been, and they shy away from new technology. They're nervous about it. So how do you motivate that?
Yeah, it is a really great question. And I think it's the number one obstacle that we all have to overcome with any kind of change, right?
Right.
Especially, I remember when we put the scanners in, and I'm like, what is that? Are you adding 15 minutes to my hour? Like, how am I going to do that? And I started scanning. I'm like, this is super, really cool. I really love this. So my initial reaction is always to cross my arms like I am now and what's in it for me, really, because I already want to take such great care of my patient. I can't imagine adopting one more thing. But when I started really seeing the aha moment with the patient, that's really what was motivating, is something that can change your entire patient experience overnight with a simple, very seamless integration of an x-ray. And I feel like with radiological AI, we're already taking x-rays, right? We're already showing x-rays. We're already printing x-rays and submitting x-rays. So it's really just a flip of a switch, whether you're using AI as a standalone product or embedded into some of the imaging systems. I think the answer to your question is we have to have an aha moment for ourselves or with our patients in order to really move past, implementation into adoption. But I think AI for dentistry is really kind of inevitable, especially when we can see how it'll make our jobs easier along the entire patient journey.
It's a great answer. And I know too, when I started using intraoral cameras, I was like, I did it one time in school because it was a competency I had to check off. And then after that, I was like, oh my gosh, it's a little bit of a learning curve. So I have more. What is the best way to incorporate this into educational curriculum? Will there be advice, suggestions offered maybe through FADE? That's a great one. FADE is the Florida Allied Dental Educators meeting. I believe it's in February.
Yes, I think, as clinicians working with AI, we have a responsibility to educate whenever there's an opportunity. I think as clinicians, we're always willing to learn. That's what I love about our profession is we're reading magazines, we're going on webinars, we just have this inquisitive mindset. So we're seeing that offices that are adopting AI, believe it or not, patients prefer to go to a dentist 87% of the time that have the latest technology. When it comes to thinking about in the educational system, it is really a way for schools to start recruiting people, believe it or not, because they have more technology. So I do think we're moving into a phase of mass adoption across, not only the US and, globally, but also into the academic space. And I would just encourage everyone to watch a lot of webinars, seek out more learning on AI, and find the best way for you to have the most up-to-date knowledge and how to safely use AI in the dental space.
Okay, that leads me into another question. Is there liability that can result from
Yes, good.
utilizing it?
Yeah, so two things I wanted to talk about. One is when it comes to liability, in our voice tool that we're able to use, you're actually having a whole nother layer, right, of protection because you're now able to record. And you do need to make sure, as I back up, that you have permission to record, whether that's in your initial forms that you have patients sign or that you ask permission. And we can record that entire conversation. So you have that in your own dashboard at all times. So that really lets you sleep at night, right, as a clinician. And we move into how is AI being used. People ask me, like, if I get subpoenaed, do I have to? Will I get in trouble if the AI found something and I didn't, right? And it's the same on a regular radiograph, right? And also, if you're using AI and you're no longer using AI, you can remove all images. So you don't, it's not like they're stored that way. But the answer that our compliance team has told us is there's not an additional liability using AI. It's just the same as if you missed a cavity on a black and white image in itself. So no additional risks. In fact, more protection.
That definitely makes sense. Okay, so this is a question because sometimes, as we know, we have challenges finding team members. So, how about new dental assistants or new hygienists fresh out of school? Sometimes there's overlapping, on radiographs. It happens, they're trained to entry level. Can AI pick up decay with an overlap?
Yes, that's a great question. Well, again, one thing that's really kind of fun is AI will now label your x-ray if it has overlap or cone cut or in over and underexposed. So that teaches the assistant that may be newer or myself that still overlaps 20 years later to retake at acquisition, right? So that's number one. But when we first started with training the AI, it did not understand anything when the image was overlapped, just like the human eye, right? It's kind of funny we get questions where the AI was trained by a human. So if a human can't see it, the AI can't see it. But we are seeing when there's overlapping, in that overlap, you'll see a little shade of gray and you'll see a little yellow or pink dot pop up. And that dot alone should just at least warn you, let's retake this image. Now we should obviously retake. I was talking to a bunch of dentalist students at the CDA and they're like, we don't need the labels. We just need the time to retake, right? I'm like, you are right, but it will see interproximal areas that are overlapped. But the better the image, the better the AI will perform, especially when it comes to bone level measurements and angulations. I'm sure any of you on this call that have used AI, you know that the more diagnostic the radiograph is, the better the AI performs.
Absolutely. Well, I think that's it for the questions because there were a few, but you did answer them during the presentation. Oh, I think there's one. I don't know if you did answer this because there was a lot of stats. Do you have a statistic on the cases, the insurance actually approving the treatment plans with AI sending in as much documentation as possible?
We are still gathering data on that.
Okay.
But yes, it is really crucial to know two things. One, I think, well, as long as I've been doing this 35 years now, I see the insurance companies continuously asking for more and more information. I heard the other day for scaling and route planning, they want a picture of the actual, you probably already know this, but of the actual schedule for how long you spent doing SRPs, which when you understand the reason of that, it's because they don't want people doing 4 quads in an hour. So I understand that.
I do.
But we will always have to present more documentation
Mm.
and being able to use AI to say, hey, Sheila, you're doing scaling and route planning today. You haven't taken bite wings in a 12-month period. Please retake those now. That's one step that's going to help with claims. And the second is just send the x-rays in that have the bone level measurements because they're really looking for 2 millimeters CEJ to bone crest. But I will get back to you once our study is complete. It's hard to track across so many practices, but it is a great question because we do want to know how helpful that is. Insurance companies are using AI, but we can use AI to really proactively help get those claims paid.
Excellent. Thank you. Well, Sheila, thank you so much. This was so informative. It's fascinating. I love change, a little intimidated by technology myself, but I still would jump on it in a heartbeat. I hope those who are on enjoyed. And don't forget, do your survey within 7 days. Thank you. Again, everyone have a great evening and thank you for your time.
Good night.
Good night.